two, one. Please start, ma'am. We are live.
Okay. Namaskar and good evening, everyone. I welcome you all for today's webinar on recent updates in the management of lung cancer. With immense pleasure, I would like to invite Dr. Major General B.N. Kapoor, who is Director, Medical Oncology, Yashoda Cancer Institute, Ghaziabad, for his welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you very much. It's my proud privilege and honor to be part of this Allied conference. And I thank the organizer for giving me the opportunity to be the part of this conference. Lot of changes have happened over the last few years in the management of lung cancer. And the life which used to be few months in a patient of lung cancer has prolonged to many years with a lot of newer advance of the treatment and the diagnostic things which has come in the management of lung cancer. Initially, we knew lung cancer as squamous, adeno, small cell carcinoma. Subsequently, EGFR, ALK target therapy came, and then came the immunotherapy for the management of lung cancer. So a lot of newer things have come in the treatment and management of lung cancer. And to deliberate all these things, we are here to discuss about the newer management in the management of lung cancer. So to understand initially, we have the molecular landscape of lung cancer. These are the molecular targets for management of lung cancer. And to deliberate on this, I invite Dr. Biren Banerjee. He is the founder and managing director of iNDNA Life Science Private Limited. And to deliberate on this, I invite Dr. Biren Banerjee. Dr. Biren Banerjee, please.
Thank you, Dr. Kapoor, and thank you, Dr. A.P. Dubey and his team for inviting me to join your illustrious forum on this recent advances in lung cancer management. I would like to begin by sharing my screen. Can I share my screen? Okay, so I think my screen is visible.
Yes, sir. Very much, sir.
Okay, so good evening, everybody. And so quickly, this 20 minutes time allotted to me, I would like to take you to the different landscapes of lung cancer. The first 5 minutes will be spent on why we are in the era of precision medicine or molecular targets. So I represent an organization called iNDNA Life Sciences in Bhubaneswar. This is one of the first indigenous DNA laboratory of India, situated in eastern part in Bhubaneswar city. And we recently celebrated World Cancer Day, and this month, February, is the World Cancer Month. And I thank Dr. A.P. Dubey's team to think of lung cancer, which is one of the commonest cancers in men in the country. So the Times of India actually on 4th of February was kind enough to mark it as the DNA of India here, and our clinic, our institute was highlighted. So I would like to thank them. So a little bit the background. I got myself trained in Ramchandra Medical College, country's first generation molecular genetics, way back about 20 years back, 22 years back. And then we did PhD in Manipal Hospital, Bangalore, did my postdoc at National University of Singapore, and came back to India to set up this DNA laboratory. And I also trained in Baylor College of Medicine to bring in the technology which was 20 years ahead of time than India. This is my team. I am nobody without my team. I have a young and dynamic team in DNA working with me 24 hours. So my key objective of my company is to develop reliable, accurate, and affordable diagnostics for Indian patients and predict and prevent the cancer disease and make it more affordable. And the goal is to actually develop a sought-after destination for making DNA diagnostics for Indian community. So the lab was inaugurated by Nobel laureate. I'm very proud to say that we are associated with the best of the people around the world. as well as government supported from DBT and Prime Minister's special advisory team. So InDNA is situated in the smart city of Bhubaneswar, which is India's first smart city, and we provide an integrated DNA-based platform for personalized medicine and molecular diagnostics. Why do we need today is everyone has a near and dear one who has suffered from cancer, heart disease, diabetes, or congenital disorder. Today, we all want to know if we will get the disease, do we have the disease, or how should we treat the disease. So we are in the era of personalized medicine because from symptom-based or intuition-based medicine, we are slowly moving to evidence-based or information-based medicine, and slowly tomorrow will be algorithm or pattern-based precision medicine. Why? Because there is no one size which fits all. The disease may be, and the name of the disease may be same, but the type and etiology, the way the disease manifests in every individual is different, as we have different glasses for different people. So there is a transition from slowly the cell-based or morphological diagnostics, which we see the cells under the microscope, towards the molecular or the DNA-based approach. So we are slowly moving towards an era of precision health, where we wanted to see the morphology from the space of Earth. If you see Earth from the space, it looks like this. But if you actually see the map of India, it is more precise. And in map of India, you see where Bhubaneswar is in Odisha, you need a Google map. And in the Google map, you want to say the way, and you can go deeper and to see find your ways in India. This is how we go from a tissue to the cell, to the nucleus, and to the DNA. So we are moving from more and more personalized approach, precise approach in this current era of precision medicine. And why do we do so? Because it has a diagnostic identity of the disease at the DNA level. We know how to prognosticate our disease or prognosis of the disease, as well as the therapeutic outcome of the treatment, whether the treatment is having right outcome or not. And most importantly, the DNA has a tool to possibly predict the disease. The future of precision medicine is already here, which was predicted about 8-10 years back by Obama. And precision oncology today is the science of treating patients with their individual genetic changes in their DNA and personalizing the therapeutic aspect for the available drugs, which is matching or as for the change in the DNA, so ensuring a better outcome and higher chance of disease survival. So the benefits of precision medicine today is the genetic and molecular information of the patient is available. The patient's personal preferences increase their extended survival rate, increasing today. As Sir mentioned, we are able to strategize the diagnostic-based treatment, and that will work best for each person. So it is personalization today, and better understanding of the underlying mechanism of the disease, whether it's aggressive, whether its recurrence will be there, or it is going to be treated by a particular therapeutic drug. Reduce cost of treatment, and side effects are also decreasing faster. Why? Because today we have a technology which has evolved in the last 20 years from single genes to the whole genome, and today we have the power for detecting genome tool in a short span of 24 to 48 hours, and the tumor stratification at the molecular level is possible. So we are in the era of next generation molecular diagnostics and molecular medicine. So let us see why we are going to study molecular medicine at so much details, taking the example of lung cancer. So targeted therapy is personalizing every cancer, and whether the cancer is of a tissue origin of the same tissue, but the genes responsible for the disease in each person is different. Why? Because the person's diet, the person's background, the person's environment, the person's age, the person's lifestyle, they're all different. Therefore, the cancer care of the past, which was surgery, chemotherapy, radiotherapy, these are three standard pillars of cancer therapy. Still today, they are the three pillars, but only few people were involved in cancer therapy. But today, we have many people, like in our clinic here, Liva Cancer Care, we have surgical oncologists, radiation oncologists, medical oncologists, interventional radiologists, oncopathologists, geneticists, molecular biologists, and counselors, and the list is growing every day. So we have a team of people treating a particular patient rather than few. Just to give you some real life scenario, A person's grandfather died of lung cancer in 1999. A friend's father died of non-small cell lung cancer in 2002. And a schoolmate died of adenocarcinoma lung in 2009. A colleague recently was diagnosed with adenocarcinoma lung with EGFR mutation and it is still surviving. So as I mentioned, the same disease, but different time point. We have about 21 years back, you have its lung cancer, then it is changed to non-small cell lung cancer, it became adenocarcinoma, and today we have a EGFR mutation adenocarcinoma. You see people are surviving, they're no more dying. So there are cases like this, and lung cancer, when it is detected by any imaging or any other detection tool, some post biopsy is done and recommended to the pathological laboratory for grading, cellularity, and finally the DNA-based diagnostics happen. So lung cancer basically is predominantly a non-small cell lung cancer disease, about 85%. About 15% is small cell lung cancer. And in NSCLC, you have adenocarcinoma, squamous cell carcinoma, and carcinoma of the epithelial cells. So therefore, you have in the small cell disease, you have the neuroendocrine origin. Now, this is the classical way we look into the lung cancer. Now, the diagnostic algorithm is changing faster in the current modern age. There is a referral physician, then there is a multidisciplinary tumor board. I just explained the members of a tumor board. Then there is a radiation, PET CT and abdominal and MRI is done. Then there is a pulmonologist, interventional radiologist or surgeon who does tissue biopsy. Then pathology does the histological evaluation. And then it is also sent for biomarker studies. The main goal is after the biopsy, within 10 to 15 working days or the 2 weeks, we should have a complete molecular stratification of the disease which we are handling, because lung cancer is an aggressive disease. Now, there's a complete therapeutic landscape which changes today. You see, if you take 100 patients, in 100 patients, you have, as I described, different types of lung cancer. But in the patients, you have different types of mutations, which I'll talk to you in the details a little later. So there are some which carry different types of EGFR mutations, some carry ALK, some carry fusions of ALK and ROS, or RET, or MET, or KRAS, and things like that. So every individual is carrying a different type of genetic changes in their DNA, but we are looking at lung cancer as a disease. So lung cancer, histopathologically, they may be classified into non-small cell type or squamous cell type. But when you take the DNA of the disease and do a sequencing or a DNA amplification studies, you get a whole lot of genes which gets either amplified, deleted, mutated, inserted, and things like that. So these changes are acquired changes. Now, most of the diseases are actually somatic in origin. There are very few germline, almost none. So these somatic changes acquire in a lifetime. Now, there are smoker type, there are non-smoker type, there are different type, diabetic type. Now, this changes happens in the different parts of the lungs, different tissue type of the lungs. And then there are loss of heterozygosity of genes, or genes lose their copies or they gain copies. And there are changes in the tissue like hyperplasia, dysplasia, cancer in situ, and finally there is invasive lung cancer. The lung cancer do not start as an invasive lung cancer. There are changes of gradual changes over a period of time, and these changes are directed by changes in your DNA. So there are different tissue types which are happening without your knowledge. Changes either in the bronchus or in the basal type or in the epithelial or in the columnar epithelial. There are different tissue of origin of the disease, and based on the tissue of origin, even the genes get mutated, or there are pressure in the genes or they drive the mutation. We call it driver mutation. So there are different alterations in your chromosomes or DNA, and the DNA alterations leads to protein alterations and metabolite alterations and microenvironment alterations. Because of that microenvironment, a tumor is formed. So the nature of the tumor has to be understood at the molecular level, not only by on the basis of their morphological or histopathological changes, but also at the level of DNA as well as the microenvironment changes. So you take a biopsy or cytology or LCNEC, squamous adeno, and like that. And there is a very common marker today as PDL1, PDL1 IHC, which we'll tell later. So there is, after this classification of the histopathology type, we go into tissue quantification for molecular. And as because lung biopsy is a complicated process, and most of the time you get very little tissue for lungs. So the tissue is always an issue, but always the tissue has to be preserved for the mutation analysis, which is so very important today for molecular classification. So, as I mentioned, that the EGFR is a mutation. It is changed in the exons. There are different exons which are detected. This can be detected at the PCR level or a targeted sequencing at the Sanger or NGS. Now, these mutations can be detected early from the tissue, or we can also see fusions or like ALK and ROS fusions by fluorescent in situ hybridization. I'll show you some before. Or we can see other mutations like BRAF and things like that. So basically, the commonest type of mutations we have in lung cancer is EGFR family of mutations, as well as the KRAS mutations or the RAS family, as well as then we have different other types of mutations which are less in number. So the workup is the lung cancer specimens are either tested directly for mutations after histopathological stratification, or if the tissue is very less, then it is taken for directly for NGS, and the mutations are detected, or if the histopathology slide is available, then FISH can be taken into. So 50% of the patients are with advanced and non-small scale lung cancer have driver mutations or targetable mutations. Thanks to that, 50% is a huge number. So you have basically mutations in the family of, as I told, EGFR 17%, KRAS, which is almost like 25%, or extended RAS family 13%, and we have about 30% unknown drivers. Now, these unknown drivers are called the black box mutations. Now, this is getting slowly more and more clear, visible, but we have enough currently to target, like if you have all, you can target with drugs like crizotinib, ceritinib, alcitinib, brigatinib, lorlatinib. You have EGFR, you can go for gefitinib, erlotinib, afatinib, and things like that. So you have each mutation has a companion drug which is targetable, and these drugs actually give very good disease-free survival today, and we have evidence-based clinical trial data available worldwide. In EGFR,
my apologies, sir. You are just left with 3 minutes to conclude your presentation. Thank you.
Okay. Yeah, that's what 20 minutes is a very less time for doing. So as I told, EGFR, there are EGFR 18, 19, or 21 or 20, and based on them, the first generation, second generation, third generation drugs are used for EGFR assay. You have different other drugs like for ROS fusion, you have crizotinib. For RET fusion, you have alcitinib, and you have ALK fusions, which you have ceritinib. So I will just touch upon some of the important areas because I have less time. Like liquid biopsy is another technology where we take the cell-free DNA floating in the plasma of the blood, and we detect mutations from these cases from different stages of the tumor. So liquid biopsy is a powerful tool for monitoring the tumor response, monitoring therapeutic response and relapse as well. And we have a whole range of diagnostic technologies. It is not only NGS, but there are FISH-based assays, PCR-based assays, and targeted sequencing-based assays, which can be used, and they're powerful and they're fast and cheaper and less costly, which is very important for Indian market. Like you have ALK fusions, which can be detected like FISH. Then we have mutation dynamics like ALK and EMLK4. Why? Because it can be used here. Mutations can be targeted, can be detected by multiplex PCRs or Sanger, and a group of EGFR and RAS families can be looked at by Sanger. So these are some of the assays which I would like to highlight due to lack of time. But yes, guidelines for lung cancer, International Association for Lung Cancer Detection, as for CAP and AMP, EGFR and ALK fusions for all patients with advanced adenocarcinoma. As per NCCN recommends, all cases should be looked for the common mutation for EGFR and ALK. PDL1 testing is very important for non-small cell lung cancer. It takes about 10 days for doing that, and we short that. Now, broad multiplex NGS panels are important, but without getting these results, therapy should not start. People should not rush into therapies which are not advisable as per international guidelines. So molecular subset of lung cancers are evolving as we speak, and till we get the complete results, chemotherapy regimen should not be started immediately, because there has to be a dynamic, dialogue between the point of care with laboratory and analytical team before we make therapeutic decisions. So decoding cancer is mysterious, and we are going from cell types to pathways to different targetomes. So the future is looking very bright and very powerful, getting from whole exome somatic mutation load to immunogenic phenotyping and to predictive assays for prognostication. So we are in an era of predictive modeling, repurposing of different drugs, and combinatory treatment with different targets. So we have centers in different places of India, and we are growing, and we are quite positive about precision oncocare today. And this is my team, and thank you very much for your time.
Thank you very much, Dr. Biren Banerjee. It was a very lucid talk, and it's nice to see that you are doing so many newer molecular testing in your lab. And this is the future of treatment of lung cancer. And I thank you and congratulate you for your very lucid talk. Thank you, Dr. Banerjee.
Thank you. Thank you.
We'll move on to the next talk, and is by my dear friend, Dr. Dubey. He will be discussing the immunotherapy in the management of lung cancer, which is nowadays the key treatment for lung cancer, and it has revolutionized the treatment of lung cancer. Dr. Dubey need not require any introduction. He is the oncologist at Shanti Mukund and Clearmedy Hospital, and a very learned person. And I invite Dr. Dubey for his talk on immunotherapy in lung cancer. Okay.
Good evening, B.N. Kapoor sir, and thank you, Rosh, for giving me this opportunity. I'm a medical oncologist and hemato-oncologist at Shanti Mukund and Clearmedy Hospital. So I'll be speaking on the optimizing the treatment for first-line non-small cell lung cancer, the role of atezolizumab, that is anti-PD-L1 monoclonal antibody. So these are the subheadings under which I'll be describing my talk. So as we all are aware that lung cancer is the most commonly diagnosed malignancy and the major cause of mortality worldwide. And among lung cancer, non-small cell lung cancer account for around 80 to 85%. And which is relatively a slower growing tumor as compared to the small cell lung cancer, with the variable initial objective response rate according to the driver mutation and the targeted therapy involved. Majority of the lung cancer, maybe around 85 to 90%, are associated with the smoking, whereas around 10 to 50% of the patients are never smokers. As per the literature, the median age of onset is 70 years, but at least in our country, this median age is at least 1 decade earlier. Metastasis occurs later in the disease process, and around 55 to 60% of the patient present in the advanced stage, where the intent of treatment is not curative, it's just palliative to prolong the overall survival and improve the quality of life with minimizing the toxicity of drugs used. This is the evolving landscape of the cancer treatment. Understanding the molecular pathways which drive the cancers, it has actually led to the development of certain agents which actually target these genetic alterations, also known as driver mutations, and thus are able to control the malignancy. And these drugs or targeted therapy are actually innocuous to the normal cells, so they have very good tolerability as well as safety profile as compared to the chemotherapy. So they have actually prolonged, or I can say significantly prolonged the outcomes in patients with targetable or actionable driver mutations. But these targeted therapy are not effective in patients who actually do not have such genetic alterations. And Thus, the prognosis in those patients where the actionable targetable driver mutations are not present remains dismal. So there's an unmet need of change in the treatment paradigm of patients with non-small cell lung cancer with no driver mutation or any actionable biomarker. So with the introduction of or the integration of immunotherapy in the treatment paradigm of non-small cell lung cancer, it has actually significantly improved the survival outcomes of the patients with no actionable targetable driver mutations. I'll be speaking on these three trials in very much brief. That is the role of atezolizumab, which is anti-programmed death ligand 1 monoclonal antibody in optimizing the treatment of non-small cell lung cancer as upfront or the first line therapy. So first coming to IMpower 110, which has addressed both squamous and the non-squamous non-small cell lung cancer. Here the patient with advanced squamous or non-squamous non-small cell lung cancer having programmed death ligand 1 expression more than or equal to 1% were randomized in 1:1 to either atezolizumab 1200 milligram per 3 weeks or chemotherapy based on histopathology for 4 to 6 cycles, followed by maintenance atezo in immunoarm, whereas chemo or best supportive care depending upon the histopathology till progressive disease. The primary endpoint was overall survival. And this is the prevalence of programmed death ligand or PDL1 expression which were comparatively matching in both the arms. And the high PDL1 expression was defined as either more than or equal to 50% PDL1 expression in the tumor cells or tumor infiltrating immune cells of more than or 10% in the tumor area. So also the baseline characteristics were well balanced between the arms and the PDL1 subgroups, including the high PDL1 expressing subgroup as well as the low PDL1 expressing subgroup in the terms of age, ethnicity, smoking history, histopathology, and performance status. So this was a positive trial because it met its primary endpoint, that overall survival, that is primary endpoint, was significantly higher in patient with the high PDL1 expressing subgroup. You can see the very beautiful separation of the Kaplan-Meier curve with the median overall survival in patient with atezolizumab arm is 20.2 months vis-a-vis 13.1 months in chemotherapy arm, with 12-month overall survival was 64.9 vis-a-vis 50% in chemotherapy arm, with the hazard ratio of 0.59 and significant p-value. And almost all the subgroups, all the key subgroups, you can say, were having the overall survival benefit in high PDL1 expressing subgroup. You can see age, except for the elderly patient, otherwise age, sex, ethnicity, smoking history, as well as histopathology or performance traces, all the key subgroups actually achieved the benefit in overall survival with the atezolizumab monotherapy in patients who were highly expressing or in high PDL1 expressing subgroup. Also, there was significant improvement in progression-free survival in high PDL1 expressing subgroup with atezolizumab as compared to chemotherapy, that is 5 months in chemotherapy arm versus 8.1 months in atezolizumab arm with a hazard ratio of 0.63 and a significant p-value. Now see the objective response rate. You can see the objective response rate in high PDL1 expressing group was around 40%. In atezolizumab arm, it was around just less than 30%. And also the duration of response was higher in irrespective of patients with high or low PDL1 expressing subgroups. Now, updated safety profile, you can very clearly see that the grade 3-4 adverse event was significantly lower in atezolizumab arm. Yes, the immune-mediated adverse events were higher in immuno or atezolizumab arm, owing to the inherent nature and the mechanism of the drug itself. But you can see the grade 3-4 immune-mediated adverse events which were grade 3 or 4 were less than 10%. All other, this is the most commonly seen adverse event with chemotherapy, which is myelosuppression or myelotoxicity or pancytopenia or GI toxicity. You can see that these adverse events were quite significantly higher in the chemotherapy arm as compared to the atezo arm. So IMpower 110 was a positive study, and it has actually met its primary endpoint of significantly improving overall survival in high PD-L1 expressing subgroup who were randomized to atezolizumab as compared to chemotherapy. And also the safety profile, as we can see, that was consistent and was significantly better than chemotherapy arm. And also as compared to chemotherapy, the safety data that were as compared to chemotherapy were consistent with those from the pooled atezolizumab monotherapy population, and there were no unexpected safety signals were identified. The second study is IMpower 150, which addressed non-squamous non-small cell lung cancer. Here, patients with stage 4 lung cancer who were chemotherapy naive were randomized in 1:1 to atezo plus chemo, or atezo plus bev plus chemo, or chemotherapy plus bev, followed by maintenance if patient responded to that particular therapy, atezo in atezo plus chemo arm, and atezo plus bev in atezo bev plus chemo arm, and bev in bev plus chemo arm until progressive disease. And the primary endpoint was overall survival. Now, what was the hypothesis behind combining all these three drugs? It was because bevacizumab actually inhibits the VEGF-mediated suppression of dendritic cell and thus improves the activation of T cell responses. And also by normalizing the tumor vasculature, it improves the infiltration of T cells. And secondly, chemotherapy causing immunogenic cell death results in release of tumor antigens. And also atezolizumab, by inhibiting PD-L1, it restores or inhibits the deactivation of T cell response. So these are the baseline characteristics which were actually matching in all the three subgroups, but few important things have to be taken into consideration. Is one is that around 14% of the patient had liver metastasis, which were balanced among all the arms, and which is considered to be poor prognostic factor in non-small cell metastatic non-small cell lung cancer. And also, unlike all other immunotherapy trials which have actually excluded the patient with driver mutation, here 10% of the patient had EGFR mutations, which was also balanced among all the three arms. And there was almost 50-50 split between the PD-L1 expressing and negative patients. Now, again, this was a positive study. There was a significant improvement in overall survival by addition of atezo plus bev to chemotherapy as compared to only bev to chemotherapy. You can see the 24-month overall survival with atezo bev chemo is 43% vis-a-vis 34% in bev plus chemo with a hazard ratio of 0.80. Median overall survival of 19.5 months in atezo bev chemo arm vis-a-vis 14.7 in bev plus chemo arm. And also you can see there was objective response rate and duration of responses were increased in the whole intent to treat population, though it was numerically higher in PD-L1 high expressing subgroups, but they were actually improved as compared to chemo bev or chemo plus atezo in all the arms. Now coming to OS benefit. As per the PD-L1 expressing, though we know that in intent to treat population, all patients actually achieved OS benefit, and that was higher. The benefit was higher in PD-L1 high patient with the hazard ratio of 0.70. You can see the Kaplan-Meier curve separating, but this benefit was also present in patients with PD-L1 low or PD-L1 negative subgroups. Now, efficacy in key subgroups. So the one very much important point to be noticed in this particular trial, that unlike all other immunotherapy trial or most of the immunotherapy trial who have actually excluded these patients with the driver mutation, this actually trial had included the patients, around 10% patients with EGFR mutation who have progressed on EGFR TKI and were randomized in the same fashion in three arms. And it was seen that atezo plus bev plus chemo has actually significantly improved the progression-free survival in these patients too. And you can see the median progression-free survival of 9.7 months in this arm B vis-a-vis 6.1 months in bev plus chemo arm. And also the overall survival benefit also was seen by addition of atezo plus bev to chemo in the patient with these driver mutation. You can see the Kaplan-Meier curve separating in the left graph. Whereas one more thing, important thing was noticed that atezo plus chemo and chemo plus Bev, there was no difference in the overall survival in the patient with the driver mutations. Now seeing the objective response rate and duration of response, you can see the objective response rate was 71% in patient with these driver mutation with a CR rate of 6%, whereas it was only 42% with chemotherapy with no CR rate. Now, the second key subgroup was liver metastasis. Liver metastasis is considered as a poor prognostic factor in patient with non-small cell lung cancer, metastatic non-small cell lung cancer, and is associated with dismal overall survival. And here it was being seen that this combination has resulted in improvement in progression-free survival in this patient. In these patients, and you can see the 6 month, 12 month, and 18 months overall progression-free survival significantly higher with as compared to Bev chemo arm. And also you can see the overall survival benefit was also in a patient who received atezo plus Bev as compared to only Bev plus chemo. But there was no difference in this survival was seen in patients with atezo chemo or chemo Bev. So this is the objective response rate and duration of response, which was significantly increased by addition of atezo plus Bev. And patients with bulky disease also same have received the benefit with this combination, that atezo plus Bev as compared to only Bev plus chemo. And now coming to the safety profile, there was higher proportion of treatment related and also grade 3 and 5 adverse event. That will be much obvious because of there were at least 4 drugs were combined in arm B, and thus IMpower 150 conclusion, again it was a positive trial and it has resulted in significantly improvement in overall survival as well as progression-free survival in patients with non-squamous non-small cell lung cancer who were randomized to Bev plus atezo plus chemotherapy as compared to Bev plus chemo. And also there was clinical benefit was observed in the key subgroup, that is this. This is the only study which has shown that patient with driver mutation when are being offered with the atezo plus Bev plus chemo has resulted in improvement or significant improvement in overall survival and as well as progression-free survival. And also the patient with liver metastasis actually had significant improvement in overall survival as well as progression-free survival as compared to addition of only bevacizumab to chemo. So this one more difference which has to be noticed if we do the cross-trial comparison, that in pembrolizumab, that is 189 study also has shown that patients with the liver metastasis have actually attained benefit with the chemo plus immunotherapy. But there's no trial which has actually compared head-to-head chemo immuno and chemo Bev except for this study. And this study has shown that there's no difference if only chemo immuno or chemo Bev are being compared. And this study is the only study which has shown that these patients with liver metastasis or the driver mutation should be offered chemo Bev plus atezo, so that has to achieve the maximal and significant difference in the overall survival as well as progression-free survival. So this is the overall survival in intent to treat population, that is 19.8 versus 14.9, whereas in key subgroup 29.4 months in EGFR mutated patient and 13.3 months in liver metastasis patients. This the last IMpower 130, which I'll go a little fast in the interest of time. This is the hypothesis of combining atezo plus chemo. That is because atezo has the ability to restore the anti-cancer immunity and chemo result in immunogenic cell death and thus release the tumor antigen. This is the trial design where the patients were actually randomized, non-squamous, were randomized to either atezo, carbo plus nab-paclitaxel or carbo plus nab-paclitaxel. A typical chemotherapy arm was being selected because nab-paclitaxel does not require steroid pre-medication, because there are certain retrospective studies which have shown that use of steroids with immunotherapy has resulted in worsened outcomes. So This study was a positive study, as like seen in other immunotherapy studies also. It has resulted in significant improvement in progression-free survival. You can see 6 months and 12 months as compared to chemo alone. Immuno plus chemotherapy has resulted in improvement in progression-free survival with a hazard ratio of 0.64, and also the overall survival with the hazard ratio of 0.79.
My apologies, sir. You are left with just 1
Okay,
minute to
so
conclude
these
your
are the
presentation.
subgroups
Thank
which
you.
actually almost all the subgroups were benefited with this combination. And this is the study which has shown that just alone addition of immunotherapy to the chemotherapy has not led to any benefit. This atezolizumab studies are the only studies which have actually included the driver mutation patients, and thus by concluding from both IMpower 150 and 130, we should actually have learned that patients of these driver mutations should be actually offered BEV plus immuno plus chemo if ever they have progressed on or targeted therapy. So these are the objective response rate and durational response, and these are the safety profile. Yes, the patient had more adverse event because of the dual effect of the two drugs being given in these patients. So key conclusion, again, a positive study which has shown the improvement in PFS and OS in patients who are being offered chemoimmunotherapy as compared to the chemotherapy, and also have improvement in objective response rate. And the safety profile of atezolizumab was consistent with the prior studies. And naturally, the adverse events were quite higher because of the dual effect of the two drugs being added, but there was no new safety signals were identified. Thank you so much. Thanks a lot.
Thank you, Dr. Dubey, for a very extensive talk, and you have covered very nicely the use of immunotherapy in the management of lung cancer, and definitely immunotherapy has improved the survival as compared to only chemotherapy, which was being offered earlier. So, newer treatment is definitely better with immunotherapy. Thanks, Dubey, for a very, very nice talk.
Thank you, sir.
Congratulations. Thank you very much. We'll move on to the next talk, and the next talk will be on alectinib in ALK positive lung cancer. And to deliberate this talk, I welcome Dr. Suman Karan, who is the consultant medical oncology and hematologist at Fortis Memorial Hospital at Gurgaon, and he will be deliberating his talk on alectinib in ALK positive lung cancer. Dr. Suman Karan, please.
Good evening, sir. Good to see you again.
Yeah.
Thank you for this opportunity to present this talk. I'll just share my slides. I hope the slides are visible.
Yes, ma'am.
Yes, ma'am. So I'll be discussing the role of alectinib, Alecensa, in the first-line ALK positive non-small cell lung CA patients beyond the barrier. So we're going to actually rush through the overview of non-small cell lung CA because we already heard about it. We'll look at a little bit about ALK testing. What are the features of ALK positive disease? What are the approved ALK inhibitors? And we'll discuss, and we'll focus on Alecensa. So how is alectinib actually different from, sorry, I think I've just skipped through many slides. So we will look at overview. Lung cancer is a significant global disease. It's the second most leading common cause of cancer, and we've got about 2.2 million cases per year. We know that adenocarcinoma is the most common cause of lung cancer, and we've got at least 72,000 new cases in women and 66,000 new deaths in the men that happen. Lung cancer happens to be one of the most common cancers in the men as well. So we will quickly look at ALK testing. Molecular testing, we know that is very important and it is recommended routinely as well. We do routinely EGFR and ALK, and these are built in our systems for diagnosis whenever we have a diagnosis of adenocarcinoma lung. Now, the overview of testing, there are many ways of testing. We have the FISH, we have the IHC, RT-PCR, and NGS. So nowadays, I mean, a lot of us do different ways of testing. Some of us do IHC. IHC comes really fast. NGS is done because tissue is always an issue. So tissue, NGS, because you can do a lot of testing in one go. And of course, we have the FISH and the RT-PCR. So I think whatever is available at your center, you could use that. So coming straight away to ALK positive disease. ALK positive disease happens to be less common as compared to the EGFR. It's relatively uniform across the ethnicity. So if you look at it in Europe, you have about 3.7%, US it's about 8%, and East Asia it's about 3.4%. So it's usually more or less relatively uniform as vis-a-vis to EGFR, which is more in the Asian population. Now, ALK positive disease is a very distinct subset of disease. It accounts for about 5% of the advanced non-small cell lung CA. They are usually non-squamous histology. They're usually never or former smokers, younger patients, women, patients who do not have an EGFR or a KRAS mutation. So it's generally exclusive mutations. Clinical characteristics, however, do not always predict that the patient has an ALK positive non-small cell lung CA. So what exactly is this, how do you define ALK positive disease? It's a rearrangement of the ALK gene, and it is a rearrangement within the chromosome. So there is a new, there's a structural alteration of the chromosome, and in this, this leads to an expression of an ALK fusion protein, and this was first discovered in 2007. So the ALK mutation is in India actually varies from about 2.7% to all the way to 13.2%. So it is, you could say roughly it's about 3% of our lung cancers, and it's mostly seen in patients who don't have a history of smoking, or probably they are never or light smokers. And the incidence have, like it's shown, is varied upon different hospitals. In our hospital, it's about 3 to 4% is a pickup rate, and it's mostly found in young population. So now we look at what are the approved agents in for the ALK positive disease. So crizotinib was the first molecule, and this inhibited both. So it inhibited a lot of receptors, the MET, the ALK, and the ROS1 and the RON. It inhibited the ALK receptor activation by blocking the ATP binding sites, and by inhibiting the fusion protein, crizotinib prevented activation of intracellular signaling pathway for regulating the survival and proliferation of the cells. So we'll look at the first trial, the trial that actually brought in these ALK inhibitors, and this was the first-line crizotinib versus chemotherapy in ALK positive non-small cell lung CA. I'll brush through this very quickly. Here, ALK was positivity was detected using FISH. So this is what I would like to highlight here. 1:1 randomization of crizotinib 250 BD versus chemotherapy, which is PEMCIS or PEMCARB, which is given 3 weekly. And what they found here is that crizotinib significantly did better. That is, you see the pink curve, versus chemotherapy. So it was 10.9 months of PFS versus 7 months of PFS, with a hazard ratio of 1.45. So there's almost a 55% reduction in the risk of progression of disease. Time to progression was very less in the crizotinib arm. Sorry, time to response was just about 1.4 months versus 2.8 in the chemotherapy arm. And you can see the median duration of response was double with crizotinib. So this is what started our interest in using targeted therapies in patients who had a molecular genetic profile ALK positive disease. And when they actually looked into the final OS, you can see that the overall survival in the intention to treat population was significantly better. The hazard ratio was 0.76. 4-year overall survival rate was 56% in the crizotinib arm versus chemotherapy at around 49%. So this is one of the landmark trials and when they actually looked at the side effect profile, crizotinib was pretty well tolerated. There were higher frequencies of vision disorders and transaminitis, but nothing very significant to cause permanent stoppage. And in fact, permanent stoppage of chemotherapy was more as compared to crizotinib. Now, the issue with crizotinib is that it is actively exported out from the blood-brain barrier. So the amount of the level of crizotinib in the blood in the brain is less. So this is the reason why the brain is sanctuary site for a further progression. It is a frequent site of relapse in these patients. And you can see the median time to progression for brain metastasis is 12.5 months versus 15.7 months. This is 12.5 months for chemotherapy versus 15.7 months for crizotinib. So crizotinib definitely did better, but then this was one of the sites of failure for this drug. So ultimately, I think all of the patients finally, you could have a local relapse of brain metastasis or systemic disease, and ALK patients typically have a relapse within 1 year, and half of them, that's 50% of the patients, progress in the brain. So some of the mechanisms of an ALK positive resistance, acquired resistance, it's very similar to the EGFR mechanism. So there are three major mechanisms. First is you have another second site of mutation in an oncogenic driver gene. So crizotinib, for example, the most common mutation is the ALK L1196M. Target gene amplification is one of the other mechanisms where you can have the EML ALK amplification itself of this fusion protein, and then you can have an acquired resistance. Or you could have another oncogenic driver, like you could have an increased EGFR activation or a KIT amplification, which could lead to failure. So numerous mechanisms exist, but the most common thing is the ALK mutation, which is very important to know. Secondary mutations are the most important cause. And later, the other mechanisms are alternative mechanisms account for a small percentage of it. So coming to ceritinib, I will not be I will not discuss this much because I think there's a talk after this about it. SN4, but here, this was discussing first line ceritinib in ALK positive non-small cell lung CA metastatic of stage 3B and 4. And here it was by IHC, and this was different from the profile study, which was by Fish. So I'll just straight away go to the curves. You can see the PFS was significantly better in the ceritinib arm as opposed to the chemotherapy arm. And chemotherapy was not the standard of care here. Patients with brain metastasis and without brain metastasis in baseline did better in both the in the ceritinib arm. Toxicity profile was also better. And what they really did find out was the GI toxicities was significantly higher in the ceritinib arm as compared to the chemotherapy arm, but rest of it was actually better in the ceritinib arm. Ceritinib and crizotinib are very similarly exported out of the blood-brain barrier, so you will have one of the sanctuary sites you will have CNS progression. So that is actually the problem with both these drugs. 46% of patients with crizotinib and 42% in ceritinib will progress in the brain, hence leading us to our drug of the talk of today, Alecensa. How actually is alectinib different from crizotinib? You can see it's a more potent drug. It has a more potent ALK and RET inhibition, that as you can see in this graph. And if you actually look at the activity profile, you can see that there's a significantly greater potency. As you can see across different mutations, you can see that there's a greater potency of alectinib as opposed to crizotinib, as you can clearly see. And you can see some of the failure mutations that you can see in crizotinib, how it actually fails. And you can see that they have very poor activity against all of this, where alectinib does really well. The radio, this is actually showing the CNS penetration. We know that alectinib manages to penetrate the blood-brain barrier. It is not a substrate for peak glucoprotein, and hence the brain to plasma ratio is really high. And that is why you do not ultimately have this kind of failures that you do see in ceritinib or crizotinib. So the activity of alectinib versus crizotinib, this is in the intracranial tumor model. You can actually see that this is how good the activity is in alectinib, as opposed to look at this. This is alectinib. This is crizotinib doing significantly worse, and then you have the control, which is obviously worse. So this is the intracranial tumoral model, and there is an apparent linear relationship which is actually noted between concentration of alectinib in the CSF when it was paired with the systemic concentration of alectinib. So you know that what you give is actually penetrating to the CNS and maintaining a good level in the CSF, which is preventing the CNS progression. So the key differences are the selectivity of it, the potency, the resistance mutation. So you saw the list of ALK fusion proteins that it can work against. So its range and repertoire of action is huge, and the CNS penetration is significant. So this makes alectinib a significantly better drug. So we'll look at what are the applications of Alecensa. We've got numerous studies. We have the AF001JP, which is a phase 2 Japanese study. You have the J-ALEX, all of us know it's a Japanese study, which had about 207 patients. Then we have the ALEX, which was a pivotal trial where treatment naive patients were looked into. And Alacia trial, this was a trial just for the Asian population, which has about 187 patients in the study. So we have 3 phase 3 trials and 1 phase 2 trial that actually support alectinib as a front line in previously untreated ALK positive non-small cell lung CA. So looking at ALEX trial had randomized the patients to alectinib versus crizotinib. And these were 3B and 4 non-small cell lung CA patients, and here the ALK was by IHC testing, and they had CNS metastasis at baseline, and that was one of the stratification. The second stratification was the Asian versus non-Asian population. So here we had, they had a good number of patients who had a CNS metastasis at baseline. You can see in both the arms. So coming right away to the updated analysis, this is the PFS, final mature PFS. You can see alectinib doing significantly better, and actually beyond 3 years, you can see it's parallel, it's almost parallel. So there's nearly 3 years of freedom from progression, and this is the entire population. And this is the first trial that actually showed you that alectinib gave you 3 times the benefit, 3 times a longer PFS benefit as compared to crizotinib at just 10.9 months. In the intention to treat population, you can look at it at 4 years, 43.7% are actually progression-free, event-free, as opposed to not even evaluable in the crizotinib arm. So we're looking at something that is significantly giving you a better survival. When they stratified it based on different profiles, whether the patient was less than 65, more than 65, whether they were Asian or non-Asian, and whether they had a previous CNS metastasis or baseline or no baseline metastasis or previous brain RT, you can see that all of them did significantly better in the alectinib arm. So consistently better, with the exception to, of course, the active smokers. And the magnitude of benefit was significantly higher. So when you look at the patients with the pre-existing CNS metastasis, the Alecensa actually gave you a 25.4 months of PFS benefit. And without, it was almost more than 3 years, that is 38.6 months of PFS benefit. And the
my apologies, ma'am, you are left with just 3 minutes to conclude your presentation. Thank you.
Protection that lasts almost, many years, irrespective of the CNS metastasis at baseline. So this was the final analysis. Patients with or without CNS metastasis at baseline did better. And at the end of 4 years, you can actually see that it was the alectinib arm that actually did better, significantly better as opposed to the crizotinib arm. So 84% reduction was seen in the risk of CNS progression. So this was a very landmark result. 41.4% of the population is free of CNS progression at the end of 1 year, as opposed to 9.4% in the crizotinib arm. So I will quickly go, to the next trial, because I want to show you these the Asian. So this is another important slide. This is the updated ALEX 5-year overall survival, and Alecensa at first line had more than 60% overall survival rates at the end of 5 years, and this is the highest for any of ALK therapy. 6 out of 10 patients are alive at the end of 5 years. So I will quickly go through. So this is something that I really want to highlight here. This is the sequencing of treatment. So if you do crizotinib followed by ceritinib followed by lorlatinib, that is what that is one of the ways of doing it. You can see that, you finally have a median PFS. It's giving you 10 plus 5 plus 6.9 months. Then if you do crizotinib, then you move to alectinib, which will give you 10.9 months. And then you do lorla at 6.9. Again, you're getting somewhere around 26 months. You do crizo followed by brigatinib, which is not available in India. You get 10 plus 16 months plus 6.9. So you would think that, okay, this is one of the ways that you could do. You could extend the life, but you don't have brigatinib as of now. Now, if you do alectinib first, you have 34.8 months. Then you do lorla, which will give you about 5.5 months. I think this is the best combination. And alectinib should be given in the first line. And this slide actually highlights it. And of course, then, you have second line, third line therapies later on based on IM power 150, which Dr. Dubey had mentioned. You have chemotherapy options and all. So I will straight away go to the J-ALEX study. I just wanted to mention the data from the Asian versus non-Asian subgroup. This was by Tony Mock et al. And you can see that the Asian populations actually did significantly better. HR rates of about 0.46 versus 0.49 in the non-Asian population. So clearly, Asian population does significantly better with alectinib as opposed to crizotinib. Again, highlighting the reason to opt for this as a first line. 12-month cumulative incidence of CNS progression was significantly lower with alectinib versus that of crizotinib, as you can see. It was the CNS progression, the percentage was just 9% in the alectinib arm versus 44% in crizotinib arm in the Asians, and the Asian doing significantly better than the non-Asian population. Alectinib is a fairly easy drug to tolerate. I think the side effects are still significantly better as opposed to crizotinib in terms of diarrhea, in terms of AST/ALT increase. It's favorable. It has a meaningful quality of life. And I think with this, I'll come to an end to my talk. Yeah, thank you.
Thank you, Dr. Suman, for a very nice talk. And as usual, you have presented your data very nicely. And definitely, alectinib has been a good drug, increases the progression-free survival. And I thank you for your talk, which was very lucid and very informative. Thank you very much. We'll move on to the next talk, and this is on MET14 skipping, exon 14 skipping. And to deliberate this talk, I invite Dr. Bhuvan Chugh, who is the medical oncologist at Max Hospital, Saket, Gurgaon, and he will be deliberating his talk on MET exon 14 skipping in the management of non-small cell lung cancer.
Thank you, sir. Thank you, sir.
Hello.
Can you hear me? Am I audible?
Yeah, you are audible.
Thank you. I hope everybody can see my slides. My video is not working for some unknown reason. I'm not able. I think. So let me just start about capmatinib, and it's a new kid on the block. There is a lot of hue and cry about the MET exon 14 skipping mutation now, and I think we have. As we use more and more NGS, we are able to obviously identify MET exon 14 mutations, not only in the beginning, but also as a resistance mechanism for most other mutations. So the slides have been provided by Novartis, and that's the disclaimer. To begin with, what is a MET mutation? MET is a splice site mutation. To understand what is a splice site, so splice site means it's the site between the intron and the exon. So intron, so as we all understand that exon is the part of the DNA which gets coded into the RNA, and that then a protein is formed. And intron is the site which is not coded and which is not which doesn't become the part of the DNA, part of the RNA and the protein. So the point between that is called as a splice site. So generally what happens at the splice site mutation is it either leads to the continuation of the coding, in which the exon which was being coded, the intron also continues to be coded with it, or the exon is totally skipped if the splice site is mutated. So what happens in a MET splice site mutation is that the mutation at the beginning of the exon leads to the missing of the entire exon 14 of MET. So the 13 and 15 are juxtaposed with each other, and the 14 is mixed. Now, for this to be identified, RNA, the next generation sequences which reads the RNA are the ones which will be able to identify it, because it's easier to pick up an entire exon being missed and a 13th and the 15th exon being combined with each other, rather than identifying a single splice site mutation which is further off, more than 100 types. So if you read the DNA frame, you'll have to actually go through 150 different types of mutation to identify that one particular mutation. However, if you're looking at the RNA, you will be able to figure out that the entire exon 14 is missed. Hence, MET exon 14 is picked up on a RNA-based NGS. Now, it occurs in 3% of NSCLC and 5 to 22% of other NS. So 3% of adenocarcinomas and 5 to 22 of other subsets. And it has been linked to early stage or early stage of metastasis, early stage of lung cancer. Now, MET exon 14 is associated with a worse survival. As you can see in the KM curves, MET positive mutation, the MET positive cancers, they tend to have a worse overall survival and disease-specific survival as compared to the wild types. So as it happens with other driver mutations, MET exon 14 also is associated with poor response to immunotherapy. So the overall response to immunotherapy is 17%. The median PFS was 1.9 and the overall survival of 18.2. And there are individual case reports that the immunotherapy, that the immune checkpoint inhibitors may not be effective against the MET exon 14 skipping mutation patients. Also, it has been seen that MET exon 14, it's a marker for poor response to the therapies which we have other than the MET ones. So the overall survival in a MET mutated stage 4 non-small cell lung cancer median is around 8.1 months, 10.5 months for the patient who only have a MET mutation, and it's around 5.5 months for MET mutation and the patients who have a MET gene amplified. However, if you look at the use when a MET TK has been used, be it crizotinib or capmatinib or gilsatinib, the range of OS is in the range of 24 to 25 months. So capmatinib is a selective MET inhibitor, unlike the crizotinib, which we all know is a ALK, ROS, and a MET inhibitor. So it's a oral competitive inhibitor which has 1,000-fold selectivity for MET receptor kinase. It is able to cross blood-brain barrier, and it has a selective, as I told you, it's more selective and it's more potent than the other inhibitors which we have. So Geometry Mono 1 study was a phase 1 and 2 trial which was done by the Novartis group, and they had divided. So they had taken patients who were stage 3B or 4, more than 18 years of age. They had to be negative for generally it's a mutually exclusive mutation. So the patients were negative for the EGFR wild type, ALK negative, MET dysregulated by a central assessment, and the performance status was less than or equal to 1. So it included patients with MET exon 14 as well as patients who had a gene amplification, which could be the gene copy number between 4 and 6, 6 and 10, or more than 10. So they had divided the entire patient population in multiple cohorts. The cohorts to be focused upon here are the cohort 4, which were pre-treated patients who had MET exon 14 regardless of the MET gene copy number, and the cohort 5, which had cohort 5B rather, MET exon 14 regardless of MET GCN, as in regardless of the MET amplification, but treatment naive. The patients were started on 400 milligram twice daily capmatinib. And the endpoints were the overall response rate, performance status, and the duration of response. If you can see, I'm sure you clearly visible that the age which was around the median age was 70 years in both the arms, both the cohorts. More than almost, I think the patient characteristic are pretty much there. What is interesting to see is that as it is with other driver mutations, most of the patients were never smoker or ex-smokers, and majority of the patients were adenocarcinomas. I think brain metastasis is present in around 11 or 15% of the patients, or around 15% of the patients. And the concurrent MET amplification, which with a gene copy number of more than 10, was present in around 15% of patients. So patients, quite a few of them had received one prior line of therapy in the cohort in the cohort 4. Majority basically had one line of prior therapy. And so once we had the results out, what was seen was there was a overall response rate in the patient who were pre-treated. The response rate was around 40%, and the disease control rate was somewhere between, but it was touching around 80%. In the treatment naive arm, it could be seen that the disease control rate was almost 95 to 96% in the by both the independent review as well as the investigator, and the overall response rate was around 67 or 70% in the treatment naive arm. In the MET exon 14, what was also seen was that the deep responses were observed in both the pre-treated patients as well as the treatment naive patients. And the median duration of response was 9.7 months in cohort 4, that is the pre-treated patients, and 12.6 months in the treatment naive patients. I think so. Similarly, if you look at the duration of in the PFS, it was 5.42 months in cohort 4 and 12.42 months in cohort 5B. So the reason we have started using the duration of response and PFS both in the newer therapy arms is because, as we have seen, that the patients, as we go about describing or finding these new therapies, patients tend to have a maintained response even after even after the drug has been stopped, and that's where the duration of response comes in. Moving forward, rapid and durable responses were seen in both the arms, and so if you can see that the cohort 5B, I think most of the patients had a very good response, and the first evaluation showed almost 82% of the patients in the treatment naive and 67%, almost 70% cohort 4. They had a response in the first evaluation only. As all these new TKIs which are coming in, I think we have gotten smarter with our drug development. Most of the TKIs are able to penetrate the blood-brain barrier, and so has happened in the capmatinib also, that there is almost a 54% had an intracranial response, and 4 had complete resolution of brain lesions. As we will move towards a phase 3 lesion, I'm sure this response rate, intracranial response, will kind of pick up. Because if you look at the response rates of the first generation TKIs in EGFR, the response of intracranial response is around 60% in the first generation, and a 90% intracranial response is there with the osimertinib. So I'm sure once we have a bigger data, this response also will pick it up there. So if you look at this 12 to 13 patient and intracranial disease control rate. So there was a good amount of tumor shrinkage, both in the in the treatment naive as well as the pre-treated arm. And the updated results, which also had the extension of the study, there was cohort 6 and cohort 7. So if I'll just take you through the next time. Yes. So there was a maintained response. There was a 66.7% response rate and almost 100% disease control in the first line. And results were almost similarly encouraging in the second line, the third line also. So just to give a gist of it, what we have seen is if somebody has a MET exon 14 mutation, capmatinib is it's a beautiful drug which can be used. Rather, they have not applied for a when it comes to the gene copy number, they have not applied for a license based on the gene copy number. But I think if you look at the gene copy number of 10, I think that's a good. It's also a good drug to start with. But however, that is not a valid. They've not applied for it. So this primarily it's for the exon 14 mutated patients. Exon 14 skipping patients. So to give the gist of the data, the median PFS in the first line is around 12.3 months. In the second line is 6.9 months. And almost similar have a duration of response also. And overall survival in the first line has been around 21 months and around 14 months in the second line. It's a very well tolerated drug. Yes, any grade adverse effects were around around 98%. But if you can look at it, majority of the grade 3, grade 4 adverse effects, they were peripheral edema, nausea, and vomiting. So to conclude, we have capmatinib, which has shown an overall response rate of around 65.6%. And in the pre-treated patient, the overall response rate is around 50% in the second line, around 40% in the second or third line. There has been a meaningful increase in the overall survival of around 21 months in the treatment naive and 13.6 months in the pre-treated patients. And it has a manageable safety profile. So for the updated result, we can safely conclude that MET exon 14 is MET exon for a MET exon 14 skipping mutation. Capmatinib is a go-to drug in today's era. Thank you.
Thank you, Dr. Bhuvan. Very nice talk. And as you have already mentioned, there were no other drug earlier. So capmatinib has been found to be very effective in exon 14 mutated MET exon 14 non-small cell lung carcinoma. And it has given very good results in the management of such patients. So thank you very much, Bhuvan, for your very nice talk.
Thank you, sir.
And then we'll move on to the next talk. It is on ceritinib, ALK-positive non-small cell lung cancer. And to deliberate this talk, I welcome Dr. Rohit Robilo. He is a consultant medical oncologist at American International Institute of Medical Science. And he will be talking on ceritinib in ALK-positive. Dr. Rohit, please.
Good evening, everybody. Are my slides visible?
Yeah, it is.
Okay. Good evening. I'm Dr. Rohit Robello. I was the ex-director of medical oncology in American Institute, and now I've joined as consultant in Ananta Medical College. I'm the assistant professor there. So today I'll be talking about ceritinib, a frontier in the first line treatment of ALK-positive non-small cell lung cancer. These slides were provided to me by Novartis, and this is their disclaimer. So what we know now is non-small cell lung cancer is a heterogeneous disease, which is defined by various oncogenic drivers. So EGFR being the most common and followed by KRAS and ALK. ALK is seen in about 7% of the population. And it is more commonly seen in the Asian population as compared to the Western population. And the EGFR rates also tend to vary from country to country, the highest being in Vietnam, where almost 50% of the patients were found to be EGFR positive in a clinical trial. So this is the general data about the various amplifications and various mutations that are seen currently in lung cancer, quite a few of which have targeted therapies right now, and the ones that do not have targeted therapies being developed as time passes by. So these are the various testing technologies that are available to us. FISH and PCR were more commonly used in the past, but I think now all of us have moved towards next generation sequencing because this gives all the answers at one shot, and also it tends to be effectively a lot cheaper too. Considering the various support programs that are provided by different companies. So NGS gives us all the answers, and this goes with the general pathologist complaint that tissue is always the issue. And getting a lung biopsy sometimes isn't as easy as getting an excision biopsy of a lymph node. Sometimes the tumor might be situated in a location where getting large chunks of tissue might become a problem. Hence, if we go through the routine, histopathology, which takes up quite a bit of tissue, and then after that we go for IHC, we go for confirmatory FISH. All this, brings us to a point where we might land up with no tissue at all. So a multi-gene test or a next-generation sequencing platform, which has significantly become much cheaper now, seems to provide all the answers at one shot, and that is why it currently is more preferred. There's the latest guidelines by the NCCN as to which all biomarkers need to be done when a patient is diagnosed with advanced metastatic non-small cell lung cancer. So the molecular testing should include EGFR, KRAS, BRAF, ALK, Metexon 14, RET, ROS1, NTRK123, and testing for PD-L1, based on which further therapy can be driven, whether it is a driver mutation driven or based on PD-L1 status. You can also consider immunotherapy with chemo or plain immunotherapy based on what the PD-L1 values are. So the ESMO guidelines also are a little more conservative, as we all know, because cost benefit or value-based medicine is more commonly practiced in the European countries and as compared to the North America. So here they currently recommend EGFR, BRAF, ALK, ROS1, and NTRK. And if they are positive, obviously you give targeted therapy. And if the PD-L1 testing turns out to be positive, immuno with or without chemotherapy based on the PD-L1 status. So the NCCN considers that broad molecular profiling is the key component to improve the care of the patient with non-small cell lung cancer. And it strongly advises using a broad molecular profile to identify rare driver mutation for which effective drugs are available. When no drug is available, obviously, if a clinical trial is recruiting patients for a particular mutation, you can always put them on that particular clinical trial. Whereas the ESMO guidelines also recommends the multiplex NGS platform as being preferable, as the number of target genes keep on increasing and number of targeted therapies keep on increasing. This approach is valuable and highly efficient. So the benefits of NGS panel testing is it's reliable in detecting known standard of care mutation with good sensitivity and specificity, accurate identification of up to 3 times more clinically actionable alteration compared to currently available diagnostic tests. NGS testing panels may provide data on all known mutations, allowing access to targeted treatments in later line of therapies. And routine nationwide molecular profiling can be considered to be feasible. Acceptable turnaround time. Right now, within 10 to 14 days, you will be able to get your results. Challenges, again, potential false positivity, and there is the turnaround time is slightly more. So one good thing is Novartis is offering the entire genetic panel, which includes all the following genetic mutations, a 12-gene lung panel, as per what the recommendation of the NCCN guideline is, for about 8,500 rupees only. So this brings the costing to a significantly low level, and you'll be able to get all the information, ALK, BRAF, EGFR, PIK3CA, and RAS, and all the information of all genetic mutations at one shot itself. So I think this is something that really can benefit the patients, because 8,500 is not a significant amount of money when a patient is affordable for these higher end therapies. So I think this is going to make sure that more and more patients actually become eligible, start taking up NGS panels and would be eligible based on various government, schemes to take some of these, better therapies that probably would not have been possible in the past. So the first line ceritinib study is the SN4 study. It is a phase 4 randomized study. So I'll just be discussing parts of the study. The key entry criteria was ALK positive, locally advanced or metastatic non-squamous non-small cell lung cancer with no prior treatment for advanced disease. They were randomized 1:1 and given a dose of ceritinib 750 mg, and or were given the routine chemotherapy that is used for adenocarcinoma, that is PEMCIS or PEMCARBO every 3 weeks, followed by pemetrexed maintenance. Crossover was allowed in this particular study. So the progression-free survival was significantly better in the arm that received ceritinib. It was 16.6 months versus 8.1 months when comparing, when you consider chemotherapy. The 24-month OS rate was 70.6%. So there was a 45% reduction in risk of death as compared to chemotherapy. So when you look at the Asian population subgroup analysis, you'll notice that there is significantly better benefit in the Asian population, where the median survival was 26.3 months versus 10.6 months. So definitely in all of these ALK-based studies, we have noticed that, the Asian patients actually tend to do a lot better than the Westerners due to certain molecular factors that we currently don't understand in complete detail. So the SN8 study was specifically done to see whether the dose of Serotinib could be reduced with taking it with a low-fat meal. So again, stage 3B, stage 4 ALK-positive non-small cell lung cancer, PS of less than 2. They were randomized based on brain metastasis present or absent and prior treatment to Crizotinib or Crizotinib naive. So Serotinib was given at 450, 600 with meal or 750 as per the SN4 study. The primary endpoint was steady state plasma concentration of Serotinib at 450, 600 and 750 mg. And the secondary endpoints were the overall response rate and duration of response. And other secondary endpoints included the progression-free survival also. So one can very clearly see that the probability of event-free survival was significantly better with the 450 mg dose. So at a lower dose, with a low-fat meal, the patients tended to do better than as the 600 mg dose or at the 750 mg dose. So currently, this is the dose that we all currently use, is the 450 mg dose given along with meal. So if you look at the duration of response, if you look at the progression-free survival and the overall survival at 36 months, the PFS at 24 and the OS at 36 months, as you will notice that the 450 mg fed group had a significantly better overall survival at 36 months and progression-free survival at 24 months. Just to note, the OS at 36 months in these patients was 93.1%, which is quite good in a stage 3B, stage 4 metastatic carcinoma of the lung. So approximately 70% of the patients diagnosed with ALK-positive non-small cell lung cancer tend to have no brain metastasis, but around 30% do have brain metastasis. But using the the benefit of using this second generation as compared to the first generation ALK inhibitor is the CNS as a primary site of relapse was seen in almost 46% of the cases with Crizotinib. But because of increased blood-brain penetrability with all these newer drugs like Serotinib or Alectinib or Lorlatinib, we are seeing that far fewer patients are failing at the in the brain because the brain penetration of these drugs is significantly better. And as you can see, the progression-free survival in patients with and without brain metastasis, definitely patients without brain metastasis tend to do significantly better than patients with brain metastasis. Although patients even with brain metastasis tend to do better with Serotinib as compared to Crizotinib. So the intracranial response rate also was significantly better with Serotinib. It was 72.7% as compared to chemotherapy with only 27.3%. So if you look at the subgroup analysis also, you will see that, the overall intracranial response, the CR rates were around 28% in the SN4 study, and the partial response rates were around 16% in the SN4 study. So there are numerous articles, one being the comparative, which compared the efficacy of first-line Serotinib and Crizotinib in advanced or metastatic lung cancer. SN4 included more, smokers, that is 8% versus 4.4%, and fewer patients under the age of 65 compared to the profile 1014 patient. Compared to Crizotinib, Serotinib was associated with a significantly longer PFS of 25.2 versus 10.8 months. In the adjusted indirect comparison with external controls, second generation ALK inhibitor was also associated with significantly better PFS compared to Crizotinib as first-line treatment for ALK-positive non-small cell lung cancer. So this is the data from profile as compared to chemotherapy. Crizotinib had a PFS of 10.9 months versus 7 months, whereas the SN4 study, the PFS was 16.6 versus 8.1 months. So definitely we know that Serotinib is a better drug as compared to Crizotinib. It has better CNS penetration, definitely has shown to have much better progression-free survival also. The progression-free survival definitely is far superior in Asian patients as compared to non-Asian patients. Also, the quality of life scores were better when a patient was put on Serotinib as compared to just taking chemotherapy. The major side effect that we are worried about is diarrhea. Diarrhea can cause significant problems to quite a few patients, but only about 5% of the patients actually have grade 3-4 diarrhea, but it is a complication that most people who have used this drug would have definitely faced. Other complications include fatigue, which can be quite severe in some patients, and nausea and vomiting. So there's a bit of GI problem that occurs with this drug. And we also need to monitor the liver function test. So these are the various studies. Lorlatinib with the CROWN trial has come out with its progression-free survival data. We are still awaiting the overall survival data. Crizotinib was the first drug, ALK inhibitor, that came in. Ceritinib came after that proved to be superior to crizotinib. Alectinib and brigatinib are again drugs that are found to be better to crizotinib in comparative studies with crizotinib. So 2012 was when ALK had a target. Then in 2015, ceritinib came in with more CNS penetration, and it's being commonly used right now. And then other drugs like alectinib, brigatinib, lorlatinib, etc. have all come into the market. So we have moved now to the third generation drugs like brigatinib and lorlatinib. And this is the current NCCN guideline that recommends all of these drugs, that is alectinib, brigatinib, lorlatinib, ceritinib, or crizotinib as the first line, as category 1 evidence, and in patients with ALK positive lung cancers. So any of these drugs can be used. Definitely the drugs like alectinib, brigatinib, lorlatinib do have reasonably good progression-free survival and overall survival data, but cost again becomes a little bit of a problem. And as we all know, as time passes by, these drugs tend to get cheaper. That is the basis of market economics. So ceritinib, currently happens to be one of the cheaper molecules in targeting ALK. It has good CNS penetration, so you're not compromising on that. So probably when you sequence these drugs in this particular way, they may not be that much of a difference, although we are still awaiting the data of lorlatinib being used in the first line from the CROWN study. So we do not know what the overall survival of those patients are going to be. The hazard ratio looks significantly impressive. But till we have that data, I think, going for ceritinib first and then sequencing it with alectinib and lorlatinib when a patient fails on ceritinib, because alectinib and lorlatinib do tend to work in certain ALK mutations that occur when ceritinib resistance develops. So this sequencing definitely is not a compromise, as can be seen in this above progression-free survival chart. So the points to consider when using ALK inhibitor as first-line therapy are superior efficacy in first line. Many patients may not survive in case you give them chemotherapy to move to second line. So the first-line progression-free survival and overall survival benefit that you get tends to make the patient more clinically fit that he may tolerate another line of therapy. No brain mets at baseline. When you're using a therapy that has significantly good brain penetration, you are going to be able to prevent brain metastasis. And even if a patient has brain mets at baseline, by using brain penetrable TKI, you avoid repeated radiotherapy in future, because giving repeated radiotherapy is kind of difficult without a gap of at least about 1.5 year minimum to give repeated radiotherapy based on what dose of radiotherapy is given primarily. And when a patient is having symptomatic disease, using an agent with rapid response is really going to improve the quality of life of the patient, which is one of the two most important factors in metastatic disease after overall survival, of course. And we always have second line agents that are available once a patient progresses on ceritinib, whereas we really are not sure what to do if you start a patient on lorlatinib and then next what. And then definitely in a country like India, where we need to practice value-based medicine, I think a cost-benefit analysis also needs to be done when trying to put a patient on any particular therapy. So to conclude, in the SN4 trial, ALK inhibitor naive patients with ALK positive non-small cell lung cancer, ceritinib showed significantly improved PFS and numerically improved OS. Data is not very fully matured. A PFS benefit was also seen regardless of the presence of brain metastasis. Gastrointestinal adverse effects are something that we will have to deal with, but the grade 4 and grade 3, grade 4 side effects tend to be less than 5%. Efficacy and safety of ceritinib was well established in Asian patient population with ALK positive metastatic non-small cell lung cancer. And we know that Asians tend to do far better as compared to non-Asians. Thank you.
Thank you, Dr. Rohit. It was a very wonderful talk. Just a small question. Dr. Rohit, we have heard both the talk, alectinib and ceritinib. Which is the preferred molecule for you?
Actually, the PFS data is significantly better with alectinib, sir. But when sequencing these drugs in the right way, I think when you look at this whole concept right now, value-based medicine, where cost-benefit analysis also plays an important role, I would go with Serotinib first, and hopefully after 2 years, Alectinib gets a little cheaper, and then I'll put the patient on Alectinib at that time.
Okay. The cost is definitely a part of the treatment. And yeah, Dubey, your comment on this?
Sir, I just wanted to ask Dr. Rohit, ki patient with brain metastasis, will you go with Serotinib or Alectinib?
No, brain mets, definitely I would prefer Alectinib because there's a much better brain penetration there. But in a non-brain metastatic patient, yeah, then I think I would prefer Serotinib.
Thank you, Dr. Rohit. Wonderful talk. I compliment your you on your talk, and thank you very much. So now we will move on to the next panel discussion in early stage lung cancer. I invite Dr. Dubey to conduct the panel discussion on early stage lung cancer.
Thank you so much. Thank you so much, sir. And thanks for Astra giving me this opportunity. The slides are provided to me by Astra. I would like to first call upon my panelist, first Dr. Suman, who is a senior consultant at Fortis Gurgaon, Dr. Bhuvan Chugh, who is a senior consultant at Max Gurgaon, Dr. Shiv Shankar and Dr. Deepen, who are at Rajiv Gandhi Cancer Institute, and Dr. Bhaskar Bhuvan, who's at HCG Vizag, and Dr. Rekha Vashisht, who's at Command Hospital, Lucknow. I think I have covered all. I haven't left anyone. So hope all of them are present.
Yes, sir. Yes, sir.
Yes, sir.
Yes.
So-
Yes.
Dr. Bhuvan.
Hello. Hello, sir.
Hello. No, Dr. Bhuvan Chugh, is he available?
Okay.
Okay, fine. So this is a 67-year-old gentleman, non-smoker, who presented with the worsening of cough. So the imaging showed a small lesion in left upper lobe. This is the PET scan, which showed around 3.5 into 2 centimeter of hypermetabolic nodule in left upper lobe, as you can see. No other disease elsewhere except for that left upper lobe hypermetabolic nodule. So naturally, we'll confirm the disease by a biopsy plus minus molecular studies. So this is quite out of box question. Like whenever you order for a molecular studies or for driver mutations, so which sample would you call as an ideal sample or ideal biopsy specimen for molecular studies? Dr. Bhaskar.
Hi, sir. Yeah. So for routine diagnosis, either we can go with the, CT-guided biopsy or surgical specimen, both of them good. But for the molecular testing, we need to have, as per your question, ideal sample means it should minimum 50% of the tissue should be tumor content should be present, and at least 200 cells of tumor cells should be present in the sample. Then we call it as ideal.
Dr. Suman. Dr.
So,
Suman.
yes, yeah. So I think I would prefer to do it on a, again, like he just, Dr. Bhaskar just said, the ideal sample should be adequate. There should be enough number of tumor cells. So I would prefer, if the patient is going to go for a resection, I would prefer to do it on the resectable lung tissue, because there is a bigger representation of tissue and we can get a better sample and better representation of the tumor cells.
Okay. We are presently not talking whether it's pre-surgical biopsy or resectable lung tissue. Now we have to, when we are confirming it, or in a case of like advanced disease or stage 4 disease, when you are getting a biopsy done. So what is an ideal biopsy specimen? What characteristic it should have so that the molecular testing can be well done and negative testing is not being done, or the failure rates are very less?
I think like Dr. Bhaskar just said, there should be at least 50% of tumor tissue should be present in it. And there should be at least, I think what is 200 cells should be there, at least should be there for the tissue to actually have a positivity rate.
Dr. Shivshankar, do you want to say anything?
I think from molecular testing point of view, there should not be much difference if adequacy of the sample is confirmed by pathologist, or either it is on a biopsy tissue or on the resectable lung tissue. Only thing is, if you are looking for some heterogeneous, if some marker which is heterogeneous in nature, for example, like R2, in that situation, I prefer resected lung tissue. Otherwise, both should be fine.
No, like suppose it is a metastatic disease, like what characteristic it should have to be called as an ideal biopsy specimen for getting the molecular assays being applied to it?
For that, I concur with what Bhaskar has pointed out, sir.
Dr. Dipen, you want to add something?
No, sir, I concur with the opinion as earlier Dr. Bhaskar sir has told.
Okay, so all of you have actually had hit the point that yes, but what literature says, I would just like to enumerate that an ideal biopsy specimen should be based on two factors. One is tumor cellularity of the sample and the detection limit of the molecular assay. So as per the books or as per the pathology books, then ideal specimen which is been supposed to be get tested molecularly should have at least 30% tumor cellularity in the macro dissection area and less than 20% of the necrosis. And also at least 2 millimeters of the area which is marked for the macro dissection. But with the rapid advance in the molecular profiling methods with the increased sensitivity, the analytical limitations of the tumor tissues has actually lessened, and the tumor samples with the low molecular cellularity as low as less than 10% can also be well molecular profiled. So going further, so this is the PET-CT report that we have already discussed, and the patient underwent CT-guided biopsy and found to have adenocarcinoma of lung. No molecular testing was being done. So Dr. Rekha, this is, as I said, that 3.5 into 2.5 centimeter and no mediastinal lymph node. So I guess it makes stage 2.
Sure.
So seems to be resectable lung disease. So what are the other staging investigations you want to get?
So earlier you have already decided biopsy has been done from the primary lesion. Then further, I would like to evaluate the loco-regional lymph node spread and screening for the distant mets that has to be done. Then I would like to perform PET-CT, which would provide anatomical and metabolic information. And in case of suspicious lymph node or distant lesions are there, then every effort should be made to obtain a pathological diagnosis by minimally invasive techniques.
Okay.
And in
So
that
we have already done a PET-CT and we didn't find any disease elsewhere except for the primary.
So then lymph node evaluation is must.
Yeah,
So it should be performed by
pathological mediastinal
endovascular
lymph
or
node.
ultrasound guided, sir.
Yeah, okay.
And in case if the results are negative, then mediastinoscopy or the thoracoscopy are required to be done, sir.
Okay, very fine. So this is resectable disease. So at least the PET-CT that is already been done in the patient, and the mediastinal pathological mediastinal lymph node sampling has to be done. And Dr. Bhuvanchuk, is he available?
Yes, please. Yes,
okay. Sir, this is a stage 2 disease. Seems to be operable. Will you get MRI in this patient?
Yeah, for sure. No, there is no doubt. Brain MRI has to be done
in stage 2.
So yes, I think anything which was stage 2 and above, right? That was the guideline in DeVita. So MRI brain had to be done.
Yes, very correctly said that all the patients with stage 2 and above should be actually considered for brain imaging. So this is the staging workup which have already been enumerated by Dr. Rekha and Dr. Bhuvanchuk. So this is no US was being done, no enlarged mediastinal lymph node was seen, medically fit, patient underwent surgery, and the pathological stage classification, it was PT2 and 1. So those surgical oncologists not present. So this is an early stage lung cancer. So I would like to ask Dr. Shivshankar, will you get the molecular testing in an early stage lung cancer? will you get them tested for the driver mutations?
Sir, in adjoint setting, since osimertinib is approved, we do as for EGFR, not all the other markers.
Only EGFR you will do. Or Dr. Deepen?
Yes, sir. As per the data of Idura trial, I would like to do a EGFR testing, sir. Based on if positive report is positive, I would like to give a benefit of targeted therapy in adjuvant setting.
Dr. Bhaskar, you will do only EGFR or you will get NGS for?
Sir, yeah, so for this, it depends on what kind of platform we are using. Okay, so if we are using RT-PCR, maybe we can use only, EGFR testing. But if you are doing NGS, the cost of the entire test is same, whether you do for EGFR or whether you do for the entire other molecules also. So I prefer to do NGS when compared to the RT-PCR because of the detection rate. And in fact, in my personal experience, I found for the same patient when I do on NGS, it came out to be positive EGFR. Previously, she had undergone RT-PCR, it was negative. So for all my patients, I usually go with NGS testing.
No.
If,
My question is
I'm telling
whether you want EGFR or other driver mutations.
So yeah, I'm coming to that point only. So for the cost wise, whether you do EGFR testing alone or the entire panel is same. So I'll get entire thing through NGS because like the new trials like Alchemist is I think completed. We have to get the data of the ALK inhibitors, adjuvant ALK inhibitors from that. So maybe this data we can reserve. Once the trial is open, we can use this data. I think we have to keep the entire panel testing ready. That's what I feel. If I do NGS, if I do RT-PCR, I'll go with the previous speaker words that I'll only do EGFR testing.
Dr. Suman, will you get only EGFR as a driver mutation or you will get more driver mutations done for this patient?
Like Dr. Bhaskar just said, it depends on the technology. So as of now, the data is for EGFR. So osimertinib only has the data right now. So ideally, we would do only EGFR, but then like he said, I would prefer to do an NGS. So I would get other mutations done. And also in our practice, we've also done it that if some other mutation is detected and the patient can't actually take chemotherapy and they are those late stage 3 months, we've actually just given them TKIs and not chemotherapy. So
there is no actually concrete evidence of getting the driver mutations done in an early stage lung cancer, and it is generally done in a recurrence to confirm the diagnosis, and also the genetic profiling of the primary as well as the metastatic disease can actually change and they get clonally reselected. But owing to the data, the Idura data which has come up, which is showing a very significant dramatic improvement in DFS, and EGFR has to be done, should be offered in early stage lung cancer. But also there are multiple studies or trials are going on for the other driver mutations like ALK. So just to participate in that study, and also if that trial's results are available, so one must actually, the International Association of the Study for Lung Cancer and the Combined Association of American Pathologists actually recommend the NGS testing even in the early stage lung cancer. Dr. Bhuvan, do you have any like in your hospital, you are working in a very big hospital, very big setup. So any idea about the EGFR prevalence in early lung cancer?
I think sir left, sir. He left a message actually.
Dr. Suman.
Sorry, I missed the question. What was the question?
Any idea about EGFR prevalence in early lung cancer?
In my hospital, very less. We don't do it also that regularly because the volume of early stage lung cancers, customers are actually less. I think you need to have a bigger setup. You need to have a very strong surgeon to actually have volume. So in my hospital, I think we hardly.
As you said, bigger setup, there were only 2 people. One, Dr. Bhuvan Chugh, he actually left. And there are 2 more left, who are Dr. Shiv Shankar and Dr. Dipen from Rajiv Gandhi.
Yeah, they would probably have a better answer to this.
Dr. Dipen and Dr. Shiv Shankar, please enlighten us that do you have any data on EGFR prevalence in early lung cancer in your institute?
Sir, actually in Rajasi, it is actually we have a disease management unit for each lung, head and neck separately. So I do not work in lung cancer unit. So even I do not know what is the exact prevalence in our hospital.
So, Dipen, do you have any idea?
Sorry, sir. I do not have an idea regarding the prevalence in early lung cancer.
Bhaskar?
I think it's around 30%. I think it's around
30%. Yeah, there's an Indian data which is around 35 to 40% of the prevalence in the early stage lung cancer. And this we have already discussed that whether you get only EGFR or NGS, though there's no concrete evidence. But after ADURA, EGFR for sure, but also that IACLC and CAP actually they recommend that an NGS to be done so as for the participation in the clinical trial. Now the patient is T2N1 and post-surgery, the molecular panel report EGFR mutation L858R. So what should be the next approach in this patient, Dr. Rekha, that in T2N1, would you offer adjuvant radiotherapy in this particular patient?
Yes, sir. I would prefer to give radiation, sir. In pathologically T2N1, sir, you say.
N1.
Yes, sir. There are definitely role of radiation is there, sir, in P2N1.
T2N1, but as far as I know now, in N1, the RT is actually avoided except for there is positive margins.
that's what.
Yeah, I agree, sir. If margins are positive, yes, definitely. But yeah, if margins are negative, then there is no any benefit of radiation, sir.
So in this patient particularly, there's no benefit of RT, right?
Margins are negative, then no, sir.
Okay. So role of adjuvant chemotherapy, Dr. Bhaskar.
Yes, sir. As per the LACE meta-analysis, we all know that around some 4 to 5% benefit with adjuvant Vinor cisplatin-based chemotherapy, and the improvement increases with upgrading of the stage. So usually from stage 2, usually we give adjuvant chemotherapy, but previously we used to give vinorelbine cisplatin, but no, we changed to PEMCIS. So there is a definitive data for this. There is no question.
Dr. Dipen, would you give adjuvant chemotherapy for this patient?
Yes, sir. Surely, I would like to give adjuvant chemotherapy with cisplatin-based chemotherapy regimen, sir. Though data with cisplatin vinorelbine, I can also give a pembrolizumab with cisplatin, and followed by the adjuvant therapy, sir. TK targeted therapy, sir.
Shiv Shankar, you agree with your colleagues?
Sir, you said, sir, it is EGFR mutated.
Yeah, EGFR mutated.
So I'll go for adjuvant osimertinib.
Direct adjuvant osimertinib.
I think
not sure. I'm not sure in the ADURA trial, though it is.
There are patients who didn't receive chemotherapy well. But this patient actually warrants chemotherapy, right? T2N1.
T2N1 more than 4 centimeter definitely warrants chemotherapy, sir. Any T size, if it is more than 4 centimeter, it warrants adjuvant chemotherapy.
So, okay, so you'll also give. And Dr. Suman, will you concur with your colleagues?
Yeah, I would give chemotherapy. I would give chemotherapy in this patient.
You'll give chemo. So yes, there are two large meta-analysis. One is LACE, which consists of around 4,600 patients, and one is Cochrane meta-analysis, which has shown around 4 to 6% of 5-year overall survival benefit in stage 2 or above patients who actually received adjuvant cisplatin-based chemotherapy. Yes, giving chemotherapy could be detrimental in stage 1, but stage 1B with the risk factor like poorly differentiated tumors or high SUV value or the invasive tumor more than 2 centimeter or lymphovascular invasion, there we can consider chemotherapy, but the data is not that concrete. So this patient actually received chemotherapy. Now, would you give one by one? I would like everyone from starting from Dr. Bhaskar Bhuvan, then Dr. Suman, then Dr. Shivashankar, Dr. Dipen, that would you give adjuvant osimertinib in this patient? Are you like convinced with the data what osimertinib has in the adjuvant setting, and what is your experience with osimertinib overall? Dr. Bhaskar.
Sir, actually, the ultimate goal of a adjuvant trial is always overall survival, not the DFS. Okay. In this trial, still overall survival is not mature. It's only showing the improvement in the DFS only. Okay,
Yes.
just we are assuming that this improved DFS may be surrogate marker for OS, but ultimately, if the OS improves, then only the trial has the validity. Okay, because you just showed some other trials also, Radiant and CTONG trials also. They also showed the DFS benefit, but at the end, again, their OS is same, whether they received chemotherapy or whether they received gefitinib like that.
Fine.
So
Can you ignore this hazard ratio?
yeah, definitely. This is one of the best, almost twice the amount of response which received with only with chemotherapy or without chemotherapy. Okay, but voice is the main endpoint for the adjuvant trials that should be considered, because we have to wait until the complete data comes. But yeah, as per the guidelines, we can give.
But you'll give or not?
Yes, I'll give. But we have to tell the patient all these things, okay? But because we don't know whether it really
but yes or no?
His overall survival or not. Yes, yes.
Yes.
Okay.
Dr. Suman.
Yes, I will give, and I will not tell. I will not give more information to the patient. I'll just tell them you have to take it. They'll get confused.
Because see the Kaplan-Meier curve, I have not actually seen these type of Kaplan-Meier curves for any other study.
Yeah, true, sir, true, definitely. This is
and
one of
with
the
such
best.
hazard ratio of 0.17, like which cannot be ignored as such. And Dr. Shivashankar and Dr. Dipen, what you have to tell about this?
So definitely, I mean, even in breast cancer, also, I mean, without any OS data, we have changed our practice, whether it is HER2 positive. If it is no PATH-CR, we have changed to TDM1. So everywhere, based on PFS, we are changing. And with this kind of difference, definitely, I would like to start patient on osimertinib.
Okay. Dipen?
Yes, sir. Yes, sir. Agree with the Shiv Shankar, sir. Though I would like to discuss the pros and cons. Most cons is the cost issue. Most of the patient in Indian subset. If the cost is not an issue, I would like to give osimertinib in adjuvant settings.
Yes, very correctly.
My apologies, sir. You are left with 5 minutes to conclude your panel discussion. Thank you.
So, very correctly said by Bhaskar that yes, we have only DFS data and OS data is still not present. But seeing this very dramatic hazard ratio, one cannot ignore this drug in an adjuvant setting, which gives a disease-free survival with such 0.17. So means there's 83% reduced risk of progression or death. Yes, there are multiple trials which have actually shown a DFS benefit and not OS benefit as same as with the osimertinib, but the magnitude of DFS benefit and the hazard ratio was not same what is being seen with osimertinib. So surely even I would also go with my panelists that I would also offer this particular drug in patients with post-op non-small cell lung cancer who have actually received chemotherapy. So even in stage 1 also, patient who have risk factor, means the risk factor, the patient who will have risk factor would have received chemotherapy. So any patient who have actually received chemotherapy because of any risk or because of stage 2 or above should be actually offered this particular drug. And also apart from the DFS, there is very reduced or very significantly reduced risk of local or local regional recurrence as well as metastatic recurrence. You can see that it is seen in only 38% of the patient compared to 61% of the patient in placebo arm. And whereas in the Radiant study, the recurrence rates were quite high. So yes, this I think all the panelists have already answered. So just one line from everyone, Bhaskar, Suman, Dipen, Dr. Shiv Shankar, like how is your experience with osimertinib as a whole, even in advanced disease or in adjuvant? I don't know that how many would of you would have actually offered this drug. Like, how is your experience with osimertinib?
So,
Bhaskar.
yeah, I used in hardly in one patient, okay, in the last 1 year. But within 4 to 5 months, patient progressed to brain mets, actually in stage 4 cancer. I used, okay, so not very great as such, okay.
But only one patient.
One patient.
So
So
you
I have
cannot
to use.
actually conclude your hypothesis on one patient.
So, sir, I have to use in more number because the setup which I see here, patients are most of scheme patients. That's why I didn't get chance to use in more number of patients actually. Okay.
Suman, Dr. Suman.
I don't have any personal experience, but my colleagues have used it, and I think their experience has been positive. It is good.
Okay.
We'll have to wait. Maybe a year is over. We'll have to wait a little bit more.
Shiv Shankar.
Sir, if it is in adjuvant setting, I have not used. In metastatic setting, I have used multiple of times. It is definitely a very good drug. Definitely better than first generation EGFR TK inhibitors. In second line, I did not get much of benefit using osimertinib, even though they were exon 20 mutations. But in the first line setting, definitely the outcomes were much more better than the first line TK, and even toxicity profile, except for thrombocytopenia, I did not have much of issue using osimertinib.
Okay. Fine. And Dipen.
Yes, sir. I have experience in metastatic settings, sir. In first line with a limited experience, sir. 2 patients. The one patient progressed after 1 month, 1 year of therapy, and the second is one continuing osimertinib without much tolerance issues, sir. So mixed bag of response with the osimertinib in metastatic settings at first line.
Okay, fine. So even I have used it in around 8 to 9 patients, and only one patient couldn't tolerate it because of grade 3-4 skin toxicity, maybe in last month. Otherwise, I found that drug to be very good. And so quite a good drug, and the efficacy wise, we know that it is better than the first generation and second generation EGFR TK. So I conclude here. So there are the key takeaways that EGFR testing has to be done in early stage lung cancer too, because owing to the definitive and dramatic hazard ratio of 0.17 in ADAURA trial. So new option worth considering for EGFR mutated patient. And yes, an early stage lung cancer is a teamwork consisted of pulmonologists, surgical oncologists, medical oncologists, and radiation oncologists. And there is an unmet need of adjuvant therapy because despite complete resection and adjuvant chemo radiotherapy also, the 5-year survival rate are only 40 to 60%. So there's an unmet need of therapies. So might be such adjuvant therapies in targetable driver mutation patients will help us to achieve much more better outcomes. Thank you. Thanks a lot.
Thank you, Dubey. It was a very informative discussion, and the panel discussion was very good. All the contributors have given the view, and it was very, very informative for all of us. So with this, we come to the end of the session, and I thank the organizer for giving the opportunity to chair the session and convene the session. Over to them. Thank you very much.
Thank you, everyone. Thank you for joining all, and good night, everyone. Stay safe, stay blessed.
Thank you, sir.
So
Thank you,
we
everyone.
close the meeting. Yeah.
Thank you, ma'am. We are ending the session now.
Okay.